Joseph Bryant, cardiac rehab lead at Domino's Farms for for Michigan Medicine, is going to speak a little bit about an initiative that started a couple years ago, dealing with distance referrals. I think unlike Penn, in how the referrals are kind of handled directly at the hospital and then sent to specific sites convenient for the patient, a lot of our referrals go to kind of our main cardiac rehab center, who then is tasked with doing all the kind of administrative legwork to get the patients approved and either come into the University of Michigan or elsewhere. I'm sure Joseph will speak a lot more eloquently about that process than I can. In some ways, they've tried to solve a distance issue, try to get patients to the cardiac rehab most convenient for them. Joseph, thanks for joining us, and take it away.
Yeah, thanks for having me. So as I went too far. How do I go back?
Okay, yeah, bottom left.
There we go. Okay. So as everyone's aware, cardiac rehab is a class 1 recommendation, been shown to reduce rehospitalization symptoms, recurrent heart attack, mortality, and increase functional capacity, activities of daily living, increase adherence to medications, and quality of life. And all of this is pretty well documented in these different studies that I have posted here. Let me get through them all here, but so I'm not going to get into them individually, but you can look through them if you'd like. Despite the known benefits of cardiac rehab, there's obviously these barriers that exist, and including distance or time to travel to a rehab center, high copays, deductibles, work conflicts, or lack of available times, lack of encouragement to participate from a physician, or even just the lack of need, perceived need for cardiac rehab. I'm sure many people have hear patients say that they don't need cardiac rehab because they're active already, when in reality, cardiac rehab's so much more than just exercise. So today I'll be speaking just about distance as a barrier in our process that we've used to help kind of facilitate a program closer to a patient's home, and a survey that we conducted in 2017. And so this is an article that we wrote and had published just this year. To provide background, in 2008, we started tracking referrals to cardiac rehab. And at that time, our university was changing our insurance provider for staff. And we feared that patients might potentially have a higher copay, resulting in lower participation rates. It didn't take us long to realize that patients living at a distance was really our #1 barrier, and copay wasn't much of a factor, although there are some insurances that do have, the $40 or $50 copays, which is being addressed by AACVPR. So from there, we decided that we really needed to develop a process to help get patients connected with the program closer to their home. We kind of looked at patients that lived at a distance of anywhere between 45 minutes or 60 miles, and really helped get them set up in a program closer to their home. And like you had mentioned, our referral process is different, especially since 2012, when we had our electronic medical record system. Prior to that, our referrals came into a work queue. If a patient lived at a distance, the discharge planners might have tried to help facilitate it, and we really didn't know what our bottom or our denominator was of the patients being referred to rehab. So we really encouraged everyone to submit that referral, regardless of if they're going to a program closer to their home. That we could help facilitate that, and we had our exercise physiologist that would contact the patient. So our referral coordinators would contact the patients initially, verify that they had a qualifying indication, review the insurance status. Then our exercise physiologist would call the patient, discuss the program options in their community. We used AACVPR's program directory to help kind of really guide us as to what are the available programs. And then we would fax relevant medical records to the program as well. And while the numbers continued to increase from 2008 to 2011, it wasn't until we switched to that electronic medical record system in 2012 that we really noticed an increase in our referrals. At that time in 2012, it was an opt-in type of referral, and eventually in 2014 we did switch to an opt-out, and we saw the numbers continue to skyrocket. And so being our health institution, we tend to get patients that will travel a distance to have their event or procedure, but they're not going to travel 18 or 36 sessions 2 or 3 times a week to come to our facility for cardiac rehab. In 2013, this is kind of when we started the electronic medical record system. We had 270 distance referrals. And so the process was pretty manageable with our staff. But then by all the way out to just this past year, we had 1,600 distance referrals. And so we really started to analyze, how can we still keep up with this demand? And so we took, this is the referral process that we kind of just went through, but we developed a Google map. And this map, basically, we took the information that we had already collected either through the AACVPR program directory or just from over time, the programs that we had gathered. And I know there's a question that compiled a list. I know that AACVPR a few years ago, I was part of the MSCVPR board, and we did a project called Finding the N, in which we were trying to find out where programs were located, and how many staff were there, how many exercise physiologists were part of it, where there was a nurse driven program or EPs. And so I think that was something that we kind of used as well to help guide us. But we took that information that we had from AACVPR and what we had gathered over time, and we were able to input everything into a Google map. And so this map has a lot of different pinpoints, and they're all kind of color coded differently. This is specific to U of M, but we indicated where the programs were located. And then, we also indicated which ones were AACVPR certified programs, which ones were U of M affiliates. So it allowed us to kind of look and see if a patient was referred to, if a patient lived in Ann Arbor, we could see that, U of M or St. Joe's, Ann Arbor were the closest to that patient. So it really helped us identify easily, just inputting the patient's address to see what was closest to them. And it was a quick and simple way versus our spreadsheet that we had, where we had to kind of look and see, and if we weren't, I'm from Ohio originally, and so I don't know all the different cities in Michigan. And so it just allowed us to save time to find out where patients were located. So this readily identified the closest CR program. And we also provided within this, when we click on the location, we had made notes of the phone number, fax number, the medical director, whether or not they had a PAD program or a phase 3 program, or if they were comfortable with LVAD patients. And so we really were able to identify the best program for that patient fairly quickly. So with our study that we did in 2017, the purpose was really to identify the patients that we had. The volume had grown so great that we really questioned whether or not what we were doing was beneficial. Were the patients actually going to the program that we were referring them to? And so we really we created a survey. We had a research group that had trained research assistants that during the summer months of 2017, they contacted all the patients that were referred and declined our program due to distance from January of 2015 through December of 2016. And they collected basic information, demographic information. They looked to see which program was closest to their home. Did they participate? How long did they participate? And then any other barriers that prevented them as well. And so we found that of the patients that were referred, in that time, 2,912 were referred. 673 participated at Michigan Medicine during that time, and 2,239 declined cardiac rehab. Of those that declined, 339 still declined due to other reasons, whether it was work restrictions, high copay, etc. And then 1,900 declined due to distance. And so we then contacted all 1,900. 663, we couldn't, they either declined participating in the survey or they were unable to be contacted. And so that left us with 1,237. 154 didn't recall us setting up that referral to their program closer to their home. And 1,083 remembered us contacting them and kind of helping facilitate that referral. From there, 834 patients did attend, and 15 attended a program that was different than what we had initially set up for them. And then 234 still stated that they did not participate. What was interesting and probably the biggest takeaway is that 469 out of that 834 or 849, I guess, stated that they wouldn't have attended if we didn't try and help facilitate that to them. So that was 55% said they wouldn't have gone to cardiac rehab at all had we not taken the step, the couple minutes it took us to find out where the best location was and fax over some records. They wouldn't have gone. So it was really kind of eye-opening that even though the volume had become greater and was starting to become time-consuming, it really was having a great impact. And we know based on those benefits that just getting a patient in for one session versus 12 versus 24 or 18 or 24 has great impact. We also asked the patients, and I didn't put it here, but over 50% attended greater than 18 sessions. So really good potential outcomes there as well. So when we were looking at the original numbers of how many patients attended our program out of the 2,912, if we just stopped at 673, our overall percent participation rate is pretty low, 25% or less. And so when we really then added up all the additional patients that were going to other programs, we really saw that we did have a much higher percent participation rate of 52%, still less than kind of what's the national goal with million hearts at trying to achieve 70, but it was a step in the right direction. So with that, our conclusion was that facilitating program closer to their home is an effective means for increasing participation. It was fairly low cost effort and had a potential impact for long-term outcomes of patients. Obviously, further quality improvement initiatives are needed to reduce other barriers, including inconvenient hours, assistance with transportation, and possible hybrid or home-based programs, which we've kind of discussed in the last couple meetings. With that, does anyone have questions?
Joseph, that was great. I think I'll echo Kate Spur here saying, wow, going to implement some changes here based on this information. As you were speaking, Mel chimed in saying he'd be happy to share this Google map, and Stephen Katayan in an email had also sent me a map kind of similar. We'll share both links to kind of all attendees, not only those who are here today, but those who couldn't be here today. This is really great. I'm curious. You alluded to it that there was kind of this rush of, obviously with the automated referrals, there's this rush of referrals, and Kate Spur earlier in the chat had noted kind of the maybe increased demand on people's time to deal with these rush of referrals, kind of unpaid time, if you will. How has Michigan Medicine kind of dealt with that? Obviously, you've demonstrated the importance of this distance referral program with the statistics you just cited, but the kind of the practical application of the trade-offs here.
Yeah, so we do have a referral coordinator, so that's helpful. So she we actually have a 1.5 FTE for referral coordinator with 2 cardiac rehab sites here at Domino's Farms in Ann Arbor, and then we also have our Bryant location. And prior to COVID, we had an exercise physiologist that was working at different offsites and testing, and we might have had a slower day or consistently where our schedule wasn't full. And so during some of her downtime, she was kind of going through and working on contacting patients and getting them set up. Some of the time is just the waiting game between contacting the patient initially for them to call you back and kind of some back and forth. But with COVID, we kind of realigned work, and so we did switch over to our referral coordinators are kind of taking this on now. It kind of saves a step because our referral coordinators were already contacting the patient to make sure that they were interested, and now they're able to identify where they want to go right away versus, previously it was the referral coordinator would contact them, then she would notify the EP to contact the patient again to find out where they want to go and then send it up. So it really, we took a step out of the process. It is still time consuming. Our referral coordinators often tell us that it's challenging to keep up. But they have been able to manage the demand, and using the map has been really helpful for them to see kind of what's the most convenient location and what is maybe the best program for them based on their medical condition.
One more comment. The map that you had provided, I know you kind of alluded to the color coding, and that some were AACVPR and others non-AACVPR. I think what strikes me is the number of cardiac rehab sites in the state of Michigan. Maybe to the folks who are dealing with cardiac rehab day to day, it's not as striking, but kind of just taking a look at the map, how kind of diversely spread across the state. Are there, and this is kind of simply my ignorance, are there kind of differentiating factors between referring to AACVPR versus not? About 67 or 70 or so, based on the current AACVPR website, are those kind of accredited sites in Michigan, but there's about 110 or so on that map. I'm just curious, and people can feel free to chime in the chat as well.
I mean, my understanding is, and we've been an accredited program since 2007. They just provide, AACP provides guidelines, and they want to make sure you're attending, that your staff are competent. They want to make sure that you have emergency preparedness in place. They want to make sure that you have, triage, in place. They also look at outcomes, and oftentimes it's graduation rates, it's depression scores, it's smoking. So it's just a way to make sure that your program is really kind of meeting some consistent measures for safety, for patient outcomes, for staff, in terms of competencies and things like that.
But there isn't necessarily let's say someone lives up in the UP and they live much further away from an AACVPR accredited site versus not. It kind of is the priority placed on them getting to the most convenient cardiac rehab site?
Yeah, I mean, it can go either way, I guess. If you have a site that is maybe a couple of miles or minutes further, I would probably go to an AACVPR program first. But there's a lot of programs that I've worked with, just being on our state board that weren't certified, and I know that the staff and the team are well competent and have the tools and resources. So, I would encourage everyone to be AACVPR certified, but I know that there's plenty of programs that aren't currently, that are still quality programs. So,
fantastic. Joseph, I really appreciate you taking the time, and appreciate you and the Michigan Medicine staff for putting that map together and the willingness to share it.